obsessive compulsive disorder. We use this term in a very regular manner, in our day to day manner, but it is way beyond it. If one is going through it, they are the ones, or the professionals, they know the severity of the disorder. So technically, OCD means repetitive intrusive thoughts, recurrent in nature, and intrusive means somebody, if you feel like you are not thinking it on your own, they are coming with some pressure. These thoughts are intrusive in nature, okay, without your will, you might feel like. It is very important to understand that in OCD, the thoughts must be recognized as person's own thoughts. These thoughts not should not be like somebody is trying to feed those thoughts into me. Then it becomes a different, entirely different thing. So OCD is that the person is markedly stressed because of these repetitive thoughts, the recurrent thoughts. They can be in the form of thoughts. They can be images, or they can be impulses, the urge to act out, the urge to make some action. So either thoughts, impulses, or images. So this is known as OCD. So when we say disorder, it means that it creates a marked significant disturbance in your social, occupational, and personal sphere. So you are not able to properly function in these spheres because of these thoughts. Coming to compulsions. What are compulsions? So compulsions are actions, okay? The actions we do in response to these thoughts. These compulsions, they can be overt, or you can observe them in the form of behavior. For instance, a very common type that we know is washing hands. Compulsion means we are getting a thought that my hands are not clean. So this is an obsession. And what I am doing in response to it, I am repetitively washing my hands. Then there are mental compulsions, or covert compulsions, are covert in nature. So what happens in these scenarios? We do mentally things in response to these. A very common mental compulsion would be continuously counting. Okay, for instance, I am getting this thought again and again that I have to count, the tiles on the floor. So I will keep on counting it. Or it might be related to religious in nature. It might be some religious in nature. So I might chant, or I might repeat some mantra in my mind again and again and again. So all these things I am not doing willingly. It's against my will. And I am feeling marked or significant disturbance in my day to day life because of these compulsions or obsessions. When a person goes through OCD, there is marked significant disturbance in concentration and attention. If I see, like if we say that what is the visible effect, so the person is not at all able to focus or attend to the present environment, or the present goal, or the target that is in front of them. Then the other symptom is the person is continuously feel guilty about doing those acts, because the person is recognizing these thoughts as their own, but he or she is not able to have control over those thoughts. So what happens is they repeat those acts in order to reduce the anxiety. Then they might have significant level of delays in performing their day to day activity. So if a person is obsessed or having repetitive thoughts related to cleanliness, for instance, a housewife, if we take, or a person who's cleaning the house, if they are having these thoughts repetitively about the surface is not clean, so they will take more than average time to clean the entire kitchen. They might do repetition of cleaning the plates or utensils again and again. So they are taking increased time to do their day to day activities. The next symptom is that apart from the attention and concentration, it also hampers their social relationships. The person is not able to convey easily to what he or she is going through. They are not able to make the other person understands because they themselves are not aware about it, right? So it causes symptoms of anxiety in them. So they might feel excessive sweating at times. These symptoms, the autonomic symptoms, might or might not be there. They come associated with it, right? These were the symptoms related to OCD. If they are predisposed genetically to it, so that means that in their history, in their family history, there is some history of mental illness or mental disorders, or the person they themselves have a personal history of anxiety related disorders, or it can be related to the personality as well, that they might have in their personality. So there is one important point that I would like to mention here is that there is OCD and then there is OCPD, Obsessive Compulsive Personality Disorder. So it is very important to differentiate between them. The people who are going through it. Okay. So if insight is present that I am getting these thoughts are mine, but these thoughts are not right. They should not be there. They are beyond the right level or the right point, then this comes under OCD. But when we talk about OCPD, this type, it's a personality type. So here in these people, they will have it as the trait. So there are people who like to clean everything, okay, and they see no harm in this. But if this is causing distress to themselves, as in they won't be accepting it. But what happens is that the family or the peers or their co-workers, they might be getting affected because of this. Then they need to visit a consultant for the same. So I've told that there is a genetic predisposition, then there is the childhood trauma or the parenting or the upbringing, any sort of abuse with the child during the childhood period with somebody, and the person is carrying the genetic vulnerability as well. Then it increases the chances of going through OCD. The environmental factor, they play a very important role. So even if somebody is carrying that genetic vulnerability in them, but there is a very strong a supportive environment, understanding parents, good academic experiences of school, no history of bullying or anything like that, then probably the chances of it expressing with a trigger, it reduces in comparison to those who get compromised in these fears. Also, there have been brain imaging studies there on the biological level. So the frontal area of the brain, there are some issues in the functioning, or there are some areas that are affected in OCD that are being found in some studies, but still it is not fully proven. So the areas that have control over inhibitions or fear and anxiety, or emotional control. So these areas, they are affected when we talk about OCD. Consultation with a doctor or a professional, uh, it all comes to them when if they are aware. First, if are they aware about it or not? So if they're aware about it, definitely they will understand it, and the reporting to some consultant is much earlier in comparison to those who are not aware about it. Second thing is, if somebody is not aware, so there is a marked significant distress in their life. So patients with OCD, so what happens majorly? Like I have seen a change in people coming or reporting OCD. So earlier, what I used to see is that people with OCD, they come like in their 30s or late 20s. They report or they come out to a professional for help. But these days, I am seeing actually, early recognition of this. Parents are also, bringing their children to a professional for help. There is slightly more awareness than before. So, as this point comes in about children, I would like to mention that OCD has as an early onset most of the times. Okay, so somewhere around 17 to 18, they come for the diagnosis. It the symptoms, they might start to appear a little earlier than that as well. For instance, the child might have an habit of doing things in a particular way, arranging or ordering things in a particular way. There are different types of OCDs. OCD is related to cleanliness. OCD might be related to hoarding or collecting things. It might be related to the religious beliefs. It might be related to the religious idols. At times, it might be related to some sexual content. It might have some sexual content as well. So, wherein religious content or sexual content is involved, people are not comfortable opening up. Definitely, it has taboo attached to it. And these two, the sexual content and the religious one, they go uh, hand in hand. The person having one might have the other. The person having the other might have the other one. So the most common forms, they still might reach to you, the professional, as in more readily or with more openness. But these two, they get recognized quite late because people, they are not open about it. They are repetitive, intrusive in nature. The person, they identify these thoughts as their own. There are unsuccessful trials of stopping these thoughts. Okay, and then these thoughts are or actions are causing marked stress in them. Marked, as in it's significant level of stress. And when these things, they start to happen with 2 consecutive weeks, there have to be few days to 2 consecutive weeks. Then we can diagnose it as OCD. But in most cases, the diagnosis, when people, they reach out for professional help, it majorly reaches way beyond the timeline. So it's very difficult for them also to understand that, okay, in 2 weeks, whether this is OCD or not. So it has a very slow progression. It grows insidiously, and then when it is by the time it affects all the spheres, and the person, the people, they realize, or the person affected realizes the need to visit a professional or for help. The disorder has significantly affected all the spheres of their life. It can be of three major types. It can be majorly related to obsession, or majorly related to pure compulsions, and at times it can be mixed. But as of my experience, and my as far as my knowledge says, that majority of the times it is the mixed type. Both obsession and compulsions are there. What happens is, what is predominant, what is made, you can see an obsession, but there can be a mental compulsion to it, which at times gets unrecognized or unnoticed. So these are a few things which are related to disorder, and also there are few terms you might see. Neutralization is there. What is neutralization? Neutralization means avoidance, that you try to neutralize the situation. So in OCD also there is marked avoidance of the stimulus that act as a cue or triggers the thought process. So people going through or suffering through it, they try to avoid it. They try to neutralize the situation. The person who's going through OCD, first of all, as a family, you might know it, or as a very close friend, you might know it. But otherwise, for people, it becomes extremely difficult to share it with someone beyond their family. So if you feel, or if you see that these might be the signs or symptoms the person that is showing might be related to OCD, so it is very important to respect whether the person is ready to discuss about it or not. If the person is not ready to discuss about it, then you can be sensitive towards them. If somebody is going through it, you are not supposed to ask unnecessarily questions related to it, or you are not supposed to give unnecessary suggestions related to it. If you feel that the person is not seeking any help, then you might approach them. And the approach should also be very sensitive. It should not be very directive, because the person might feel attacked. They might not open in front of you. As far as if the person, and there is the family, if the family is aware, specifically for children, so I would suggest parent to be as much patient with the child as they can, and to immediately start with the treatment. Okay, so if there is an early onset, so it might be an indicator of poor prognosis. So in order to deal with that, poor prognosis means that you are predicting that there are less chances of recovery, right? So unfortunately, there are like there is no 100% recovery out of it, but there are many instances where people are able to manage it quite well. And along with pharmacotherapy, along with medicines they might be needed initially when there is excessive level of anxiety, but in the long run, psychotherapy is required. Psychotherapy is very important in the long run, because it actually helps the person to understand it, to manage it, to build the coping mechanisms to deal with it, and it has worked effectively. So the primary type of psychotherapy involved here is CBT, and the subpart of the CBT is exposure and response prevention. As the name says, I will give a very brief introduction. Exposure and response prevention. If you see the name, so exposure. So say, there is very high level of avoidance in OCD. So what you do is you gradually try to expose the person to the stimulus, to the stressor that creates it, right? So then the response that they are bound to give, okay, that or that they have been forced because of OCD to give the compulsion. So they have to stop it. They have to prevent that response. They have to prevent themselves from giving that response. For instance, if somebody has they have the OCD related to cleanliness. So if they're repetitively cleaning their hands, so that doesn't mean that they will stop going to kitchen only. Okay, they will stop using utensils only. If they think that by touching something, their hands they might get dirty or infected. Okay, so we are supposed to have a proper hierarchy of these exposures. We have to have a proper exposure plan to it, and gradually we can expose the person and prevent he or she from giving those responses.